I'm going to talk today about what is, for me, the long game, and it's actually elimination of disease, which is the reduction of disease incidence to zero in a defined geographical area, and this defined geographical area is this beautiful planet we live on. We really need to have deliberate efforts to achieve elimination, and then, when that's happened, continuous efforts to stay there. Elimination of disease, this came out of the MMWR. It said elimination and eradication are the ultimate goals of public health. They carry with them an awesome responsibility, which I know you all carry on your shoulders here. And there is no room for failure. But the only question is whether these goals are to be achieved in the present or some future generation. I'm going to talk about the elimination of disease in terms of tuberculosis and hepatitis B and C. And I'm going to do it from a clinical perspective, because that's what I am, a clinician. What are the clinical developments that can contribute to all the other efforts to help eliminate these diseases? Now imagine a disease. Imagine a disease that's spread through the air. It sounds like science fiction and has infected 2 billion people around the world, 1 in 4 of the population, that's become a leading cause of death from infections, surpassing HIV, where 95% of the cases and 98% of deaths are in the developing countries and comprise 25% of all avoidable deaths. Imagine a disease where 75% of the cases are in the economically productive age group 15 to 50 years. That disease is tuberculosis. It's been the #1 killer over the past centuries. Nearly 9.5 million people become sick with TB every year, and 1.5 million people die. That's 4,400 people every single day from tuberculosis. This is the so-called long game. Can TB be ended by 2035 here? Well, if we carry on as we are, and we're doing okay, we're working hard, if we carry on as we are, we won't get there. We really need to optimize our current tools and pursue universal health coverage and social protection. But by 2025, we should have new protective drugs to prevent TB and a new vaccine, and then we can really get going and average about 17% year drop. If we don't do that, we won't make it. We need a new TB vaccine. Our old one's 95 years old. I'm not saying being old is not so good. I'm standing here today. But we need a new vaccine that could prevent adolescents and adults from developing and transmitting TB. And it would be the single most cost-effective tool in mitigating the epidemic. Even if we had a vaccine that was only 60% efficacious, and we only gave it to 20% of the people, we would avert until 2050 up to 50 million deaths. Each life is precious. There is a global pipeline of TB vaccine candidates, and we hope by the time we get to 2025, at least one of these will have come to fruition. So now let me turn to the combined elements of TB and HIV. The size of the problem: over 1 million new TB cases in HIV-positive persons and almost 500,000 deaths every year. 80% of these are in this Africa region. And TB has become the leading cause of death amongst people living with HIV and AIDS, accounting for 1 in 5 of all the deaths. Now, how can we optimize, and I showed you on that graph, optimizing our current tools of clinical management? Firstly, we have to find the TB cases. We have to treat them with TB drugs and with antiretroviral therapy. We also have to find those people who are at risk of tuberculosis. We treat them with antiviral therapy and give them preventive therapy to stop them getting TB. But we have to be part of a big integrated service. We can't just stay in our silos and just do one thing. We should have a universal public health approach to do this. We are finding too few TB cases too late, and almost half of the TB cases are diagnosed are not diagnosed prior to death, half of them. Now, we can use microscopy to try and diagnose TB by looking at patients' sputum. It's time-consuming, it's laborious, and it's difficult. So we need technology. And we have technology. This machine here, the Expert MTB RIF machine, has been endorsed by WHO to actually be used in preference to microscopes. It takes 2 hours to get a result, and you can even tell whether you're rifampicin resistant or not. And at the weekend at TB 2016, we heard other drugs could be tested using this machine. This has had a fantastic rollout. And again, we heard at the weekend, 10 million cartridges of this have been used. And in fact, I was told it's now 16 million. The rollout of this machine has been quite phenomenal. And we are now having other machines being developed. Go to a small village with a handheld machine. Everybody could spit in a pot. You could check them. It's battery controlled or solar powered, and you could have an answer. Technology can help us. Now imagine you could just pee on a stick and have a diagnosis of tuberculosis. Sounds incredible, but it's true. And there is this special test called the LAM, which looks at remnants of tuberculous cell walls in the urine and will pick them up. It is useful in people who've got very low CD4 counts or people who are seriously ill, and it's been shown that if you make the diagnosis earlier, it has a mortality benefit. Peeing on a stick to diagnose TB, technology can help. Now, we do have to test for HIV in all TB cases. Everyone with tuberculosis should have a test. And how are we doing for this? Well, you can see here in the African region, we're doing pretty well, but we must do more. And even in Europe, we're still not achieving 100% HIV tests in our tuberculosis cases. Some people say to me, how could that person possibly have HIV? We've heard that story before. We also have to treat all the TB HIV cases with both TB drugs and with antiretroviral therapy. It's important we remember that. The trouble with TB treatment, it's complicated. At least 6 months, lots of pills. We've tried to shorten the treatment, even just down to 4 months, and these trials have tried to look at that and not worked. We're still left with 6 months, and we can't even use some of the things that we thought we could to try and predict which are the best drugs that might work by looking at the sputum cultures at 2 months. But Cliff Barry's been looking very carefully at novel ways, at the sort of pharmacodynamics and biology of the lesions to try and get a handle on how we might be able to treat patients and maybe limit the number of months that we give therapy for. Now, if you have TB and HIV, is your outcome in terms of getting better from your TB affected by the HIV status? Yes, it is. If you're HIV positive, you're twice as likely to die from TB than HIV negative. And again, at this meeting at the weekend at TB 2016, we saw some data from Merle, from WHO, that actually those patients with low CD4 counts, if you double the dose of rifampicin, increase the dose, you actually have a mortality benefit. So things are moving, even using old drugs in new ways. Now, what about antiretroviral therapy for people who have got tuberculosis? How urgent, how quickly must you start HIV treatment? Well, this is a very old paper from my history where we looked at a whole cohort of patients and we found, and I know this is remarkable when you think about it today, we found that if you had a low CD4 count and you weren't on antiretrovirals, you had a high risk of dying or progressing to more AIDS. And it was fantastic that we got the highest quality trial evidence from all around the world, including here in South Africa, showing that you really need to start antiretroviral therapy in people with TB quickly. And it's been developed by the WHO guidelines. If you have a very low CD4 count, you should do it within 2 weeks, otherwise within 8 weeks. It has to be done. And how are we doing? Well, when you look at it, of all the people we know with HIV TB, 77% are getting on antiretroviral therapy. The issue is, you can see here in the top line, there are a lot of TB patients who are not tested, so we don't know what's happening to them. And if you do the sort of maths, you see that only a third of the total who could be on treatment are actually on it. So we have to do a little bit better. Now let me turn to prevention, because prevention's better than trying to treat a disease. We all know that. So can we prevent TB in people living with HIV or at high risk of developing TB? Firstly, antiretroviral therapy prevents tuberculosis in people at risk of it. And we've seen this from the two When-to-Start trials, the Temprano and START, and other cohort data that came before it. But these were randomized studies. But actually, to maximize prevention, you also have to add in some TB preventative therapy. So you give patients antiretroviral therapy and you give them antiretrovirals. And here's some data from Brazil and Africa. And you can see if you just give preventative therapy alone or antiretrovirals alone, it's not as good as giving both together. So ART alone's not sufficient. You have to give patients at risk of TB some anti-TB treatment as well. And it's usually given for isoniazid for 6 months. So you have to take a tablet for 6 months. So people are now saying, do we need to do that? Can we do something that's a bit shorter and give less doses? And this here, rifapentine with isoniazid, given once a week for 12 weeks. That's 12 doses of pills only. The 3pH is something that people are looking at and putting into trials. And you can see here, this beautiful work from the New England Journal showed it was just as good as the other strategies at the time. So where is preventative therapy going? I've just said there are novel therapies and strategies, and in fact, it may be that if you're HIV positive at continuous risk of TB, you take this short course of rifapentine and isoniazid once a year to try and prevent you getting TB. If you've been exposed to MDR TB, then there are trials going on looking at different drugs to try and prevent you catching it. Now, instead of giving preventive therapy to everybody at risk, maybe we could find out who is at most risk. And there's some very interesting, and it's technological work looking at RNA expression in genes, 16 genes, and actually if you come up positive for that, you're much more likely that you might develop TB in the next year, so you'd be high priority for preventative therapy. There's also no imaging techniques using PET scans. Obviously, the applicability to this to resource-poor countries isn't there yet, but if you can develop something where you can pee on a stick, I'm sure we can develop something here that can be easy enough. We have the will and we have the knowledge. So how are we doing? Well, you can see here a big rise in the number of people going on preventative therapy, but there is still a lot to do in Africa in terms of getting this going. Now let's put all this together. Prevention, antiretroviral therapy, treating cases, and also embedded in this is improving programs. I'm not talking about that today, but you have to remember that. And you can see that we are doing something good. We're reducing deaths from HIV TB since 2004 by 32%. But this is the long game. We have to keep going. A short note about MDR and XDR TB. And the real thing about this for clinicians is we need more effective drugs, we need less toxic drugs, and we need shorter course therapy. To go on treatment for up to 2 years with lots of therapies, with injections for the first several months, is very, very difficult for any patient. So you can see here a list of new drugs, and we're even discovering old drugs to use in MDR, XDR, which have been used in other areas of medicine. And just this month in the Lancet, beta-lactams have also been shown to be effective. So we are finally getting there with drug therapy for TB. You can see here the number of people across the globe who've been treated for XDR, but the drugs are really expensive. And in South Africa now, at least 2,000 patients are on a new drug, bedaquiline, but it is costly. Our group have looked at this, and we've said, can we afford to treat everyone with new TB drugs? Well, actually, if you look here, the amount of drug bought at the moment to treat, special drugs to treat MDR, XDR is about $173 million. And if you look at these are 4 different drug regimens for MDR TB, 4 different ways of treating. You can see these are the number of patients we can actually treat with this money. If we move to generics, which we could do very quickly, everybody could be treated because this is how many people there are with XDR. We could treat everybody we're using these regimes with these drugs. We need advocacy, of course, and Nelson Mandela said we can't win the battle against AIDS if we don't also fight TB. And it is wonderful that so many groups, organizations are doing this, that they're fighting with science, advocacy, and policy. I now want to move towards the elimination of viral hepatitis. And there have been set standards now by WHO trying to get 80% of people on treatment by 2030. And the think tank said a world where viral hepatitis transmission is stopped and everyone has access to safe, affordable, and effective treatment and care. That is the world we want, not the world we have today. Hepatitis, viral hepatitis, is one of the leading causes of mortality and trends. And I know this looks like a big list, but it's really interesting. Viral hepatitis has gone from 10th to 7th cause of death in just a few years. Let's think about hepatitis B. It's a total unmet medical need. If you see this, half of the cancers of the liver are due to hepatitis B. There are nearly 750,000 deaths. And it's incredible because we have all of these overlapping epidemics of HIV and hepatitis B. You can see here there's 4 million HIV patients with Hep B. But if you look at the total Hep B community, what can we do? We can prevent it. We have an effective vaccine. Here's some data from Moldova where they increased the rates of giving vaccine to babies. We have to do that because look what happened to hepatitis B infections. Almost disappeared. And that we really need a global pressure now to give all infants at risk hepatitis B vaccination. And you can see what the effect of this is. Hepatoma, liver cancer, goes down if you effectively vaccinate children. Now, if you are hepatitis B positive, we do have treatment for this. But the problem is treatment, a bit like with HIV, doesn't eradicate the disease. It just keeps it under control. We have a lot of drugs here, and the mainstay actually at the moment are 3 drugs, tenofovir, lamivudine, and entecavir. Now, if we look at the price of tenofovir and 3TC around the globe, you can see it's 1,000% difference between Russia and Botswana. We need better pricing for these drugs. So if you're hepatitis B positive, you cannot have to pay this price. We've also looked at entecavir from our group, and you can see here what the US pays. The list price, $15,000. We've estimated that from the raw product all the way to making it generic and giving the generic company a profit because they're a company, we could do it for about $36. Why is there a gap? But for those patients who are infected, we need cure. And in Paris next year at AIDS, the science meeting, we're going to have a whole symposium on cure for Hep B. And we really need to target this one area here in the DNA to try and eradicate the hepatitis B virus. You can see there's lots of therapies on the way and lots of interest in this. Hepatitis C is huge. You can see here of the world's population, there's a large number of people infected with chronic Hep C and very few aware. We need more testing. And the burden, a large burden of this is in resource-poor countries and in infection drug users who, as you know, time and time again, have such poor access to healthcare, such poor access to treatment. They need to have a voice in when we plan treating hepatitis C patients. People say, who should we treat with hepatitis C? In my country, they're only treating people who are really at this end of the spectrum, this F3-4. I say everyone should be treated, and we should follow the models like in Portugal, where anyone with hepatitis C can get treatment for it. Hepatitis C therapy has changed. In the old days, back here, old days, 1990, okay? For me, it's yesterday. For some of you, it's the old days. Okay. So we had very poor response rates with very difficult injectable drugs. Look at what we've done now. And I will support everybody in this, including the pharma companies who've developed these drugs. Everybody has to be congratulated that we've got to the stage that you can take 12 weeks therapy and be cured of hepatitis C and have very few side effects. But can we afford hepatitis C treatment for all? Here again is our group. We looked at it here. This is what the United States list price is, $84,000 to cure your hep C. And this is what you could do if you made it generic and gave the generic company a profit. The cheapest you can get from generics at the moment at $324. You could get it for $62. So what is the impact? What's the impact of providing these drugs? Well, we could reduce the incidence of hepatitis C down from 10 million to 1 million cases by 2030. And we could reduce the mortality from 1.3 to under 500,000 deaths. Imagine what 800,000 people look like, and they're still alive because we've given them drugs. It's a phenomenal image, and please keep it in your mind. But we need also harm reduction. Here's a graph which says, this is what we show here. We do nothing. If we had harm reduction on its own, look what we could do for hepatitis C. And then if we clean up the blood supply and we give drugs, we can look towards elimination of hepatitis C. We really have to have continual scale up of harm reduction, and we have to involve the people who want the harm reduction. Right? So they have got to be users, people who are infected by hepatitis C, etc. They have to have a voice. Now, finally, the spirit of the elimination agenda is not business as usual. I hear too much of that. We've got to say, is elimination feasible and affordable? But that's not really the question. The question is, how can we make it work? We must learn from the HIV response. We've had fantastic civil society advocacy, and without that, the politicians won't listen. We need large-scale donor funding. You've heard that from every speech given from this podium, but it's true, we do. And the cost of drugs, I'm so fed up with the cost of drugs being put on the agenda. There'd no longer be an issue. And Andrew Hill said this the other day, the new 90-90-90 should be. It should be $90 to treat HIV, $90 to treat hepatitis B, and $90 to cure hepatitis C. We cannot talk any longer about silos, and I'm a doctor and we love them. We love to say, I'm in the TB service. I'm in the HIV service. I happen to be in both, but I try and keep them together. And look, this is what we develop. And it's fantastic that with everybody's leadership from WHO and everybody else, they want it all integrated. And wherever you go now, we have to think about that. But I think we have to do more. Look at this model for hepatitis C management. We have to put them all together. We cannot have, here's a service here, here's a service there, and go to that one there. People just won't cope with that, and nor will we. We have to see how all of this fits together. TB and hepatitis care should be part of an integrated service delivery health model, and we have to move towards that. But we also, and we know this from tuberculosis, that tackling social issues of overcrowding and poverty needs to be in the plan. And I do not want to hear too many people say lots of words. I want to see a lot of action from the words so that we can actually deliver this across the globe. For me, the long game of elimination means no one's left behind. It's not a case who's first past the post. Hey, we've eliminated X or we've eliminated Y before you've done Z. We all have to work together to get there. Thank you.